introduce Tara Whelan. As I mentioned before, Tara lives and works in Canberra. She's a pharmacist and a diabetes educator. She gave a terrific talk at Low Carb Canberra last year on type 1 diabetes, because Tara is also a woman living with type 1 diabetes. You can find that particular talk on our Low Carb Canberra YouTube. It's well worth having a look at. But without further ado, introducing Tara.
Thank you, Dr. Liz, and of course Tracy, for inviting me here to speak today. It is such an honour to speak amongst some of the greats that we have here today, including the three people we just heard from there. So, thank you. So today I'm actually going to talk about polycystic ovary syndrome and gestational diabetes. As I was introduced, I am Tara Whelan. I'm a pharmacist and credentialed diabetes educator. Today, talking about polycystic ovary syndrome, it's actually a fairly new interest of mine. So in terms of metabolic health and diabetes education, so in my clinic in Canberra, I am receiving more and more referrals for women with gestational diabetes from the endocrinologist or their obstetrician. One thing that I'm actually finding is that when we look through their history, a striking thing is the number of women with really strong risk factors for diabetes in pregnancy, and one of them being polycystic ovary syndrome. And so what I'm finding is, looking at the history, polycystic ovary syndrome, having to seek support in their fertility journey, perhaps going through IVF, and then ending up with this metabolic condition called gestational diabetes. So for me, I really wanted to look into what was going on and why am I seeing this so commonly. And what I found when I researched to be able to help these women is I ended up coming full circle all the way back to low carb. So that was really interesting. So I want to share with you some of my findings. So first of all, we are going to just outline what polycystic ovary syndrome is. We're going to look at signs and symptoms, getting to the core of the problem. We're going to look at pregnancy alongside polycystic ovary syndrome and gestational diabetes, the impact on future generations, and whether a low carb diet can actually help in this scenario. So polycystic ovary syndrome, it's most common endocrine disorder in women of reproductive years. Interestingly though, we do actually know that this might be when it's diagnosed, but there is a lot of evidence showing that this syndrome actually starts in utero in genetically predisposed females. We will touch on this a little bit later, and it does actually first present in puberty, so with girls that might be gaining a little more weight, have severe acne and perhaps some more hair growth. So looking at what, and also some issues with their periods moving forward. And it's actually in the reproductive years, actually affects up to 14% of women in this age group, so really quite common. So what does PCOS look like? So some women with PCOS may have central obesity, excessive hair growth on the face, chest, back and buttocks. They might have oily skin and suffer from acne, perhaps a male pattern baldness or a receding hairline, a lower tone of voice, and a skin pigmentation called acanthosis nigricans. And we can actually associate all of these signs and symptoms with masculinity, which we'll link back to the hormonal condition soon. So there are also reproductive consequences of polycystic ovary syndrome. So what we see is polycystic ovaries. So this is a condition of many immature follicles within the ovary of these women, which leads to a situation where they're unable to ovulate, or they're not ovulating very often, perhaps only a few times a year. And obviously without ovulation, we can't fall pregnant, and then we have an issue with infertility. Once these women fall pregnant, or we assist them to fall pregnant, we can see complications through the pregnancy, such as an increased risk of gestational diabetes, preeclampsia, and unfortunately an increased risk of miscarriage. Further on from that, we do see fetal complications as well. So we can have small or larger babies, and perhaps babies that need to spend time in neonatal ICU. So further on to what PCOS looks like, perhaps what it looks like in terms of reproduction, we also have the huge metabolic consequences. So we see increased risks of obesity, type 2 diabetes, heart disease, sleep apnea, cancer, Alzheimer's, and non-alcoholic fatty liver disease. And we've all seen this list many times before. And what do we relate this to? That's insulin resistance. So if we look back at all of the signs and symptoms that we've talked about, we can actually see disease process over the lifespan. And so we do know that it's not just a reproductive year thing, and it actually affects women all through their lifespan, through their later years and into elderly life, with these metabolic consequences taking effect. Sometimes I see women in my clinic room, often referred to me perhaps in their 50s or 60s with a new diagnosis of type 2 diabetes. Sometimes they do take on a shape and a look that might resemble PCOS. And perhaps if I look back through their medical history, I might notice a few things. And sometimes I can pretty much map out their history, and perhaps they think I'm a little bit of a psychic. Because I make some assumptions and ask them about it. One of them is that I often ask them whether they played hockey. And I always take a stab whether I say hockey or netball. And the reasons being is that, as you'll see soon, polycystic ovary syndrome is actually highlighted by the fact these women have high levels of testosterone. So a lot of these women in their younger years are drawn to high contact sports, and the biggest two that we see in women is hockey and netball. So they're quite flabbergasted that I know that they played hockey. But I can also tell them that they probably gained more weight as a teenager, had some acne, had delayed periods. Perhaps they found it hard to fall pregnant. And these women were having babies in the 70s and the 80s. And the other striking thing that I see is perhaps they're coming to me already in their gym gear. So these women are already health conscious. They're already trying to do the right thing about their diet, but despite that, they may still be sporting a larger tummy. Perhaps they do have some thinning of the hair, maybe some acne scarring. Perhaps their doctor's already put them on a blood pressure medication and perhaps a cholesterol medication. And unfortunately, they're still landing in my office with type 2 diabetes later in life. So what is the problem? So there are 100 genes implicated in development of PCOS. And so all of these genes are actually leading to one central problem, which is insulin resistance. And it is the model that's largely accepted as the cause of many of the issues with PCOS. So as we know, insulin resistance actually leads to hyperinsulinemia, or production of a high level of insulin that's required by anybody else in the population. And what we actually see is striking statistics that hyperinsulinemia is actually present in 85% of women with polycystic ovary syndrome. And it's not just weight determined. So yes, while 95% of women with PCOS who are obese have hyperinsulinemia, but also 65% of the normal weight women with PCOS as well. This chart here is just highlighting some of the pathways that has insulin resistance at the core. So hyperinsulinemia can directly affect and cause hyperandrogenism. And what this means is a high level of testosterone in a woman. Of course, we've also got hyperinsulinemia leading to our metabolic issues and also leading to the reproductive issues, and then the high levels of testosterone also contributing to reproductive issues, as well as the masculine features that we see. So how does high levels of insulin lead to high levels of testosterone? So high levels of insulin directly affect the testosterone level, and there's actually two main ways that it does this. So from the pancreas, we can see if we have a high level of insulin being produced, this has a direct effect on the ovary. And the ovary actually rebounds to create more testosterone. So there's your first mechanism. And then secondly, what insulin does is affects the liver, and it decreases the production of sex hormone binding globulin. Now, the role of sex hormone binding globulin is to actually bind to testosterone and carry it around the body. When there's low binding globulin, there's more free testosterone, which means there's more testosterone available to cause an action at different sites of the body. So this is two mechanisms how high levels of insulin directly create high levels of testosterone for these women. The other issue that occurs with the fertility, if you have a look at the diagrams of the ovaries, insulin directly affects the way that a follicle will mature in a lady. And so normally in a healthy ovary, we have follicles that are at different sizes and stages of life. And a follicle needs to grow to a certain size in order for it to be able to pop an egg out, which is what ovulation is. And so under the direct influence of insulin, the follicles all remain at this reduced state of growth. And when we have a reduced state of growth, none of them are able to get big enough in order to pop the egg out. And this is how we get a situation where these women are not able to ovulate. So PCOS and pregnancy, let's have a look at the picture. So it is the most common cause of treatable infertility, and it's mostly caused by that problem of not being able to ovulate. We do have somewhat of a segmented care look at the treatment of pregnancy and PCOS, where we do use a lot of drugs to induce the ovulation. We can introduce IVF for these women, but unfortunately we're not addressing the underlying cause here. IVF is also very expensive. It can cost up to $8,000 out of pocket for a family per cycle trying to go through IVF. And according to my investigations, it did actually cost Medicare $237 million in the past financial year. Once we're able to successfully have these women fall pregnant, they're actually up to 2.4 times more likely to develop gestational diabetes. And this was also found to be the case when women prior to pregnancy were on medications such as metformin, which is used for the treatment of diabetes. It didn't actually reduce the risk. So even with medication on board, it really just highlights the need for lifestyle modifications pre-conception and throughout the pregnancy to reduce this risk. Another striking statistic is to say that these women, once pregnant, are 5 to 8 times more likely to develop type 2 diabetes later in life. So let's look at gestational diabetes. So gestational diabetes is defined as diabetes diagnosed through pregnancy. And it's not just a polycystic ovary syndrome problem. Gestational diabetes rates have actually tripled since the year 2000 in Australia. Now, this can be contributed to a number of factors. One of them is that we did have new guidelines for diagnosis in 2014-16, and we lowered the threshold in which we diagnose gestational diabetes in terms of blood glucose measurements. So this has artificially raised the number, but we've also seen a striking correlation between the obesity rates in the general population and gestational diabetes as well. So strikingly, we found that in 2017, mothers-to-be were unfortunately, a fifth of them were obese and just over a quarter were overweight. We're also seeing women of high gestational age, so women who are actually falling pregnant later, which also increases this risk. So how does gestational diabetes affect a pregnancy? So pregnancy is already an insulin resistant state. Now, what happens when a mother is growing a baby? About halfway through the pregnancy, a number of hormones that are created by the placenta are actually coming through the placenta into mum's body. And what they're doing is actually blocking the action of mum's insulin in her own body. So what this does is if mum's insulin isn't working properly, blood glucose levels start to rise, and any excess glucose that's in the blood will be diverted through to baby. What's important is that while the glucose goes through the placenta to baby, mum's insulin does not get sent through the placenta. So what happens is this high level of glucose in baby stimulates its own production of insulin. And we know that insulin is a growth hormone, so this leads to the babies taking on more body fat and growing bigger and bigger, perhaps beyond the needs of the requirement for the survival of the birth. As pregnancy does advance, these adaptations of the metabolism actually increases the requirements of insulin by up to 2 to 3 times by the end of the pregnancy. So what this means is if someone already has pre-existing insulin resistance, so perhaps someone with polycystic ovary syndrome or obesity, this means that a woman's metabolism cannot actually cope with the extra insulin demand, and this is when we tip over into gestational diabetes. So just in terms of complications of gestational diabetes, it's important to recognise that women with diabetes who fall pregnant or those who are diagnosed with gestational diabetes have every chance to actually have a very successful pregnancy, a very healthy pregnancy, and of course deliver a healthy baby. So this list is just an increased risk, and this is why we need to actually monitor these ladies very closely. So issues for mum is an increased risk of miscarriage, preeclampsia, of course a cesarean or assisted birth, and purely because of the size perhaps of the baby going through the birth canal. We might see some preterm birth and also obviously that high risk of type 2 diabetes later. In terms of potential issues for baby, we are seeing bigger babies, which can then through birth lead to injuries such as shoulder dystocia. And remember that when baby's in utero and receiving a lot of sugar, its own insulin levels are ramped up. When we deliver baby, the glucose supply is cut off because it's no longer coming from mum, but baby's own insulin is still really ramped up. And so this can result in hypoglycemia for these babies, and perhaps they'll need to go to NICU to balance out their blood sugar levels. And as we're going to see soon, there's also an increased risk of metabolic consequences in the future for these babies. And what we're actually talking about here is epigenetics. So there's lots of growing evidence that shows us that a person's metabolic future can be written or influenced before they're actually born or actually even conceived. So this is not just limiting to genetics in terms of the genetic material that's passed on from mother and father to their offspring, but it's actually the environmental factors such as nutrition, smoking, alcohol, physical activity and stress of the parents. And these environmental factors, even when they're around before baby is conceived, as well as through the pregnancy, can also affect the baby's future metabolic health. So this is called epigenetics, and it's the environmental factors that actually affect how the genes are expressed and which genes become dominant, and therefore affects fetal programming. So what we can see then, if we have a lady with gestational diabetes or obesity, we can actually start to influence the fetal programming quite significantly. So we're actually increasing the risk of metabolic issues later in life for these children, including obesity and type 2 diabetes. What this means, unfortunately, when we give birth to these little girls, unfortunately, they're behind in their metabolic processes, and they're the ones that are going to go ahead and be the new generations of mothers that are then going to go through pregnancy, perhaps with a higher risk of gestational diabetes, polycystic ovary syndrome, and obesity. So this is why, more than ever, it's more important that we have early lifestyle interventions to minimise these risk factors of insulin resistance and metabolic disease. And this is so important for breaking that vicious cycle through the generations. So can diet play a role? So the International Evidence-Based Guideline for the Assessment and Management of Polycystic Ovary Syndrome in 2018 actually state that there is no benefit of any one diet type in the management of polycystic ovary syndrome. So what they actually recommend is reducing energy intake to promote weight loss, and they're actually talking about an up to 30% energy deficit. And we've actually reverted to recommending the general health eating principles as per the general population. So we've had a lot of discussion this morning about the calories in, calories out factor, and I'll actually add to that in context of PCOS in a moment. So the statement that we made in terms of there is no benefit from any one diet type was actually only based on three studies. And the first two, if you just look at this side here, two studies were actually based on the same parameters, where we had two groups of people going on a 55% carb diet versus a 40% carb diet. And what we found was that there was no significant difference between the diet, and they were measuring things like weight, their testosterone levels, and the glucose metabolism. And don't forget, this was women with polycystic ovary syndrome. And as you can see, the thing that we adjusted in those studies was the protein intake. And the other study that this statement was based on was the one on the right here. And so that actually took the parameters of macronutrients of 52% carb, 18% protein, and 30% fat. What the difference between the two groups with women with PCOS is that one group were asked to use principles of a DASH diet. So they were asked to find their macronutrient portions out of whole foods, so whole grains, whole vegetables, whole fruits, low-fat dairy, and low-salt products. And then the other group were asked to find their nutrients from wherever they wanted. So they were able to eat processed food, refined grains, and sugar, as long as they stuck within the parameters of the macronutrient portions. And we probably don't need to go too far into it to realize that a whole food diet perhaps performed a little bit better. So for me, I perhaps don't think that we've really investigated many different broad spectrum of different diets that perhaps could help with polycystic ovary syndrome, and perhaps this is quite a narrow view of what we could be looking at. The problem that also was raised here is that because the evidence that they found was not very strong, what we did was we reverted and looked for evidence in the wider population, and what we did was actually extrapolate what would happen in the general population and made recommendations based on that to a group of women that have very specific metabolic needs. And for me, I don't think this is quite fair. So does low carb have anything to offer? So with the theories of low carb nutrition, we can see that obviously when we eat low carb, we have a reduced insulin response. And when we do this, we're actually concentrating on that central model of hyperinsulinemia and targeting the main problem of many of these issues. So when we reduce the level of insulin in these women, we can actually get a reduction in the production of testosterone, and of course an increase in the sex hormone binding globulin, and this again will limit the amount of free testosterone. As I said, we have discussed keto diets quite a lot this morning, but just to add to that, some of the studies that we have done actually show that women with PCOS actually have an increased ghrelin response. So ghrelin is our hunger hormone, and this actually increases a lot higher in calorie restriction. And so this is the diet that we're recommending to these women, and it's even harder for them to stick to this diet because of their quite big response in their hunger hormones compared to the rest of the population. So it is really important that we start to formulate their diets to stimulate satiety, and evidence is showing that adequate protein and ketogenics may be the way to do that. So some promising results. This was a study that looked at 30 women with PCOS. They went on a diet for 8 weeks each. They were eucaloric, so the same amount of energy intake. We did have a switch from 55% carb to 41% carb, but the difference in this one is we actually adjusted the fat intake of these women. What we found is that in the high carb diet, there was a modest weight loss of 2.2% compared to the lower carb diet, which actually lost 3.7%. The most important part of this was actually looking at where the weight loss came from. In a high carb diet, we actually saw significant loss of lean total mass, which puts us in a worse metabolic position than when we started. And with the low carb diet, what we saw was a significant loss of metabolic harmful fat. So that's that intra and subcutaneous abdominal fat and also intramuscular thigh fat. We found lower insulin levels, and we also got this fat loss, don't forget, without calorie restriction, which is really key here. This study here was a pilot study of 5 women with PCOS, and we actually put them on a ketogenic diet, so less than 20 grams of carbs for 6 months. Some of the great results we saw was 12% drop in body weight, a 54% drop in fasting insulin, which again is key here, and then unsurprisingly a drop in the free testosterone as well. We also saw decreases in glucose, HbA1c, triglycerides, and perceived body hair. And two women actually fell pregnant despite previous infertility in this study. This here was a case series of 4 women with PCOS. They did 6 months on a ketogenic diet, so 20 grams of carbohydrate. We found a weight loss degree of 8% to up to 20% for these women. And these women had very long histories of infertility, so 2 of them up to 4.5 years of previous infertility. What's really striking here is that these women actually normalize their menstrual cycle. So what that means is that they actually started ovulating. And remember, this is the source of infertility. And this only happened after 1 month and up to 2 months of being on a ketogenic diet for these women. And 2 of the women actually fell pregnant in the time, despite the 2.5 and 4.5 years of previous infertility, which is really significant. One of them did have other fertility issues as well. And let's look at some large scale stuff. This meta-analysis of random control trials included up to 176 women. And what we can see is that the low carb versus the high carb diet showed significant improvements in BMI, in HOMA-IR, which is our insulin resistance score, follicle stimulating hormone, which is required to mature the follicles in the ovaries. The sex hormone binding globulin was also improved, and cholesterol as well. So just a couple of people to mention, pioneers in this area who I'm going to be keeping a very close eye on is Dr. Jason Fung and Dr. Nadia Pataguana, who have actually found that they accidentally got many women pregnant through their clinic, where Dr. Jason Fung looks at low carb diets and of course intermittent fasting. And our very own Tim O'Dowd, who's an obstetrician gynecologist and IVF specialist on the Gold Coast. So he actually introduces a nutritional lifestyle program, which is really exciting for someone who's going to potentially make lots of money doing IVF, is actually trying to get these women healthy before their pregnancy. So, and Tim, of course, has done many talks for Low Carb Down Under as well. So just really quickly in conclusion, PCOS can have significant metabolic and reproductive consequences. And we know that these are largely driven by insulin resistance and hyperinsulinemia. These metabolic issues can be passed on to the next generation, and low carb nutrition really does offer a promising way to influence the progression of metabolic disease, and it offers a way to potentially minimize the effects on subsequent generations. Thank you.
Thank you so much, Tara. Now it's about 1 o'clock, I think, or a bit before 1 o'clock. At this stage, we're due to have a break and resume at 1:30. So stay posted. in the next half hour until 1:30, when we resume with the formal talks, there may be some informal presentations. We haven't quite worked out what's going on. There have been a lot of questions and comments come through on our chat line. I'm having a bit of a hard time trying to keep up with everything. We'll do our best to answer many of those questions. Apologies in advance if we don't get to answer everything. We're going to have Tracy's back now. We're on a break now until 1:30. That's a break from formal talks. But Tracy, do you want to do some informal chats?
Yeah, I'll get my phone set up and I'll run around and have a chat. Is there any questions that might have come through?
There are lots of questions that have come.
Okay.
Lots of questions and comments that have come through. But I think let the speakers have the opportunity to go and have something to eat, and we'll figure out how we're going to address questions and comments. Okay.
What's the first presentation after the break?
What's coming up after the break is a session on fibre, and it's Tara again for 10 minutes. Then I'm going to talk about does fibre matter, and then we're going to introduce Melissa Luxmore, who's going to give us her perspective on fibre. Back at 1:30, but stay posted because there's going to be all kinds of things. Actually, one comment that came through was that there seems to be a big disconnect between the advice from the Dietitians Association about what to do about gestational diabetes and PCOS, and actually what we think is happening. Would you like to talk about that disconnect?
Yeah, I guess not being a dietitian, but having particularly a special interest in it, is that unfortunately in the world of pregnancy, we don't have many people putting their hands up for clinical trials for diet in pregnancy. So again, very little evidence available, and all we can really do is respond to the individual in front of us. So in terms of what our bigger, higher bodies can actually start to advocate for, is largely based on what evidence we do have, and perhaps it's very little. And again, in pregnancy, and as a pharmacist I see this as well, is that clinical trials in pregnancy, obviously we have a lot of ethical issues and a lot of high risk. So it is an area that, yeah, it is like quite controversial, and it seems to be this sacred time in a woman's life where we don't want to start to push the boundaries in case there is something that does go wrong. And if we stick to guidelines, then as healthcare professionals, we're kind of in this safety net in that regard. So, you know, pushing the boundaries in pregnancy, just really controversial. Yeah. Okay. All right. So it's lunchtime. So I'll my tech help is helping me switch over to my phone so I can run around with my phone.